evening. Thank you for being here. I'm Ken Johnson, CEO of the healthcare system. Thank you for coming to our first course, and especially thank you for coming on a Monday night instead of a Tuesday night. So we appreciate that. We're going to talk about quality tonight. Companies are defined by the quality of their products and services, and we're certainly no different. Quality directly impacts an organization's reputation and is key to satisfying patients and customers. We also put an emphasis on quality improvement for all of our departments. One of the ways we drive this development is through what we call the President's Quality Award. This is an annual competition that allows staff to show how they have improved patient care techniques and processes within their department. And this is applicable through every organization within our healthcare system. We have some folks behind me that we're going to introduce here in a minute. They're going to talk about the things that they've done, and they're actually our winners of this competition. Even though we have lots of presentations in the room, lots of folks participated, we ended up with 3 winners within our competition, and they're going to share with you. But first, I'm going to introduce Janet Farrell, who's our Director of Quality. Janet has worked here for 18 years and facilitates improvement projects throughout our hospital and our healthcare system. She teaches and coaches staff on methods of improvement and also coordinates our Joint Commission accreditation process. She will now talk with you about the improvement processes we use, and then she'll introduce our winners. Thank you. Janet?
Thank you.
Is that?
Yeah, we have to move it a little bit. I'm not as tall as you.
How's that?
Okay, how's that? You hear me okay? Okay, good evening. It's good to see you today. We want to share with you a little bit about how we do improvement projects throughout the healthcare system. We use a methodology called Plan, Do, Study, Act, and that's just kind of a fancy terminology for how do you document trial and error. Sometimes we'll see a process that could be made more efficient. We could improve quality of care. We could improve the financial outcome. There are a lot of different things that we can look at in a process and see how that can be made better. And so on the back of your program, you'll actually see this little colored circle that says Plan, Do, Study, Act. And I just have a few notes on there for you so you can see what that means. And as you hear the presentations tonight, and as you look at the posters around the room, you will see how many of them use the Plan, Do, Study, Act for their documentation. One of the things that you may not know, but in healthcare, documentation is very, very important. And if we want to be paid by Medicare, if you want your insurance company to pay for things, they want it documented very well. Well, that carries throughout everything that we do. And so we use the Plan, Do, Study, Act model, and that's just where you have a process you know you need to improve, so you have a plan on how you're going to do that, and then you actually make a change. And then you have to determine if that change really improved the process or not. And then if it did or did not, that's the act part of the cycle. And it's shown in a circle because until you're perfect, there's always room for improvement, and you just keep working on it. It's a continuum of care. So that is kind of the gist of that whole process. So we had 11 projects submitted for our President's Quality Award, and they were asked to demonstrate their project through using PDSA. And the posters are on display for you to see tonight. Our third place winner of the President's Quality Award came from the Birthing Center, and you're going to hear about that. And then the second place was the outpatient rehab services. And then first place came from our emergency department. And so we just want you to sit back and enjoy these presentations and hear about what we've been doing to make things better. So I'll introduce to you Jill White, who is the director of the Birthing Center and our Women's and Children's Services. There you go.
Hi, good evening. As she said, my name is Jill White. I'm the nursing director. I've worked in the hospital here for about 10 years now, and in my current role for a little over 3. And for our project, we decided to work on breastfeeding with our newborns and moms. So I will just kind of go through and tell you what our process was like. A little bit of background. We know that breastfeeding is really critical and highly important for our newborns and for our moms, both from a health and nutritional standpoint, but also from a psychological standpoint with that bonding that happens between mom and baby. So there's also a lot of increasing attention given to breastfeeding right now across the nation and throughout the world on really increasing that exclusive breastfeeding, so not giving any formula to baby. So when we look at Joint Commission, as Janet mentioned, we are Joint Commission accredited here. And so one of the measures that we are looking at and have to report on has to do with that exclusive breastfeeding as well. So it's really been brought to our attention more and more over these last couple of years. So we had a plan that we wanted to increase our exclusive breastfeeding rate here in the hospital. And we really first identified that we needed to go back to educating our nursing staff on really how to best support our moms and babies to exclusively breastfeed. There's a lot of variety across nursing depending on how long you've worked and what you've seen in your years of experience that really kind of shape how you provide that care to patients. So we wanted everyone to start back over kind of at square one with that education that we wanted them to have on helping those moms and babies. We also wanted to set out to collect some data just so we knew where we were even starting from. So the first quarter of 2016, we spent the time collecting data and discovered we had a baseline rate of 56% of our moms who exclusively breastfed. That compared to the Joint Commission average rate of 53%. So we really felt pretty good about where we were starting off, above that national average, but knew that we had room to do better. So we set the goal for ourselves of increasing that exclusive breastfeeding rate to 64% for the fiscal year of 2017. So that would have started in July of 2016 through June of 2017. So what we did to help achieve this goal was started with that education piece. And across this time span that we'd been doing this data collection, we'd also partnered with the Reno County Health Department, the Hutchinson Clinic, and many other healthcare organizations across the county to develop what we called Becoming a Mom, which was a perinatal curriculum designed for prenatal education, but also healthcare education. So we worked together as a collaborative to provide staff education through what we called a Breastfeeding 101 class. And it was just getting back to the basics. What do we want our moms to know about breastfeeding and how can we help them be more successful? And one thing that came out of this was moms always feel like their babies don't get enough to eat. They're always concerned, my baby's not getting enough. I need to give them that formula. So doing some research, we found some tummy sizes, and we all have them on our badges now. And so when a mom says, my baby's not getting enough to eat, we can show them on day one, your baby's tummy is only the size of a cherry. It's tiny. It doesn't take much to fill that little tummy. And that has made a huge impact on our moms feeling reassured that their baby is getting enough to eat. Their tummy is full. The baby is getting everything that they need from you. They don't need the formula. We also, this was prior to this, but kind of along the same timelines, Stephanie Kaufman, who's here with us this evening, was able to obtain her IBCLC, which means she is a certified lactation consultant. So we have her on our staff here in the hospital. So she meets with all of our moms during their hospital stay and follows up with them afterwards. So just that support piece for them. And then in May of 2017, we were designated as a high five mom and baby hospital, which means we follow 5 steps to encourage breastfeeding, which you can check out on our poster back here. But basically it has to do with leaving baby with mom as much of the time as possible, not bringing that baby out of the room, encouraging skin to skin mom and baby right after delivery, and then frequently with those feedings, not using pacifiers, not using formula, anything that's supplemental to breastfeeding, really focusing on those frequent, regular feedings in those first few days to get that established. So in studying our progress, here on our graph you can see As we go into the fourth quarter of 2016 through the first and second quarter of 2017, the green line there was our goal of 64%. The red line was the Joint Commission average, and we were really able to move that exclusive breastfeeding above our goal rate. 2, meeting a 66.5% exclusive breastfeeding rate, so really excited about that. So just kind of in a recap, this project really impacts the quality of care that we're providing because we know that breastfeeding is best for our babies. It has a long-lasting positive effect, and we know that throughout a lifetime, those initial feedings are very important. And this just goes to show our commitment to excellence and providing that high-quality care to our patients. So what's next? Like Janet said, it's on a circle. We're ever analyzing and looking at what we can do better. So in looking at our data, we're going to start looking at those moms who almost breastfeed exclusively. Maybe it was 1 feeding or 2 feedings that they gave their baby a little bit of formula. So how can we continue to educate those moms on, not needing that formula and just exclusively breastfeeding? Thank you.
Thank you, Jill. Next, we're going to have Lori Hartnett come up and talk to you about her project, and she's the director of our rehab services.
Hello, I'm Lori Hartnett. I am Director of Rehab Services. I've been in that role for 4 years. Before that, I was hired in 2009 as a speech therapist for the Rehab Services Department, and I'm going to tell about my growth goal process improvement. So we know that in healthcare, there's a shift that's moving from inpatient focus to outpatient focus. People aren't staying in the hospital as long as they once did. There's more and more help and services to try and keep people out of the hospital. So we knew we needed to do something to help support people when they still needed a little bit of therapy, but they weren't in the hospital setting. We wanted to position our department for that growth. We wanted to ask ourselves, how can we grow outpatient therapy? What are the needs of our community, and how can we meet those needs? In setting a goal, the hospital system had a goal for 2% growth for outpatient services. So I used that same goal for my department. We set a goal for 2% outpatient growth. So you can see our baseline numbers and then what the goal numbers would be. And that's based on procedures. That's not per visit. You might come in for physical therapy and do walking for 15 minutes and have the therapist work with his hands on you for another 15 minutes, and that would be 2 procedures. The first thing we thought we would do is focus from the front office. We wanted to see if there was anything we could do to reduce the number of patients that didn't show up to their appointments. These would be folks that had an appointment, they didn't come to it, and they didn't call to tell us that they weren't going to come. That happens, unfortunately, fairly frequently, so we wanted to see what we could do to maybe prevent that. If it was someone was forgetting to come, we started doing reminder calls. So if you've been one of our patients, you get a nice reminder call from Jo the afternoon before your appointment, and she's just reminding you of your therapy, time, and appointment. What we found was sometimes when Jo makes that call, or if a patient calls in to cancel their appointment, we were able to move other patients up into that slot. So we were able to sometimes get people seen 3 days sooner than what they had originally been scheduled. And that was a really big patient satisfier. We also decided to utilize some reports that we get. We're able to see the last visit date on a report that we get, and if the visit date was out 2 weeks, we were able to see, did the therapist still want that patient to come? And if so, we were making that phone call to the patient, trying to get another schedule. Sometimes it just falls through the cracks, so we were able to use the report to help mitigate that. In looking at what our community needs, we discovered that there might be a community need for Parkinson's disease. There were 2 active support groups in Reno County and 1 in McPherson. So we thought there's a population of people out there that might need our help. I submitted a proposal to the Hutchinson Regional Auxiliary, and they agreed to fund 7 therapists to get this specialized certification. And then we did social media marketing for that new certification and our new service. And there's the group right there. So how did those things work? The reminder calls didn't have an overwhelming impact on the no-shows. We still have those times where someone just doesn't come to their appointment or call to let us know that they aren't going to be able to. But like I mentioned earlier, we're able to get notification if someone has a conflict and they can't come. We have at least 12 to 24 hours advance notice to try and get someone else moved into that slot. Sometimes that's really beneficial, and if we call someone and they don't want to move, we don't make them. They can come if that works for them. That also improves the therapist's productivity. So instead of having a big gap in their day, by moving other patients up, they're able to stay a little bit busier too. And with the utilization of reports, in 1 month we found 9 patients that had fallen through the cracks. They were supposed to come back for more therapy. The therapist had recommended it, but they weren't on the schedule. So we were able to make those phone calls and see if they wanted to get back on the schedule. Not all of them did. Sometimes people graduate themselves from therapy and think that they're doing better and they feel good, and that's fine too. But with these phone calls, at least we all were on the same page. The new Parkinson's certification equaled a new service line. LSVT, which is Lee Silverman Voice Treatment, BIG for physical therapy and occupational therapy, and LOUD for speech therapy, was achieved the end of April. So we had 2 months of the fiscal year we were able to collect data on how that new program was going to work. We had 2 patients referred for the LSVT BIG and 7 for the LSVT LOUD. That's pretty traditional. Parkinson's affects the voice and speech and communication a little bit before it might impact the movement and the gait and balance. We even had 1 patient, they traveled from over an hour away to come and see us because a family member had read about our service on Facebook. And then we're having some exciting outcomes. We had a gentleman who was using his motorized scooter in the home because he was falling too frequently. And at the end of our program, which is 4 weeks, he was walking without the use of an assistive device at all. He came in for his 2-week check, and he still is not using an assistive device, no cane, no walker, and no falls. Here is my data. The horizontal yellow line is my goal, my target. Breaking my 2% growth goal down per month, I needed to at least hit that yellow mark to stay on track for a 2% growth. And you can see we exceeded that in 11 out of the 12 months. And if you remember, we achieved the Parkinson's certification the end of April. So May and June, those numbers include the new certification that we had. Overall, we exceeded any expectation that we had at the start of this process improvement. We actually achieved a 24.8% increase in outpatient procedures. So we're going to continue to do what we were doing, the front office strategies. We're going to keep doing the reminder calls. We're going to keep trying to pull people up into those canceled appointments, get you into therapy sooner. We're going to utilize the reports, see who's fallen through the cracks. That way you don't think we forgot about you. And we're going to keep looking at new opportunities, find out what our community might need us to achieve and to help them to become more independent. And again, we did exceed expectations for outpatient growth.
Thank you, Laura. Another good project. Now I'd like to introduce to you Teresa Ellis, who is the Director of Patient Care Services in our Emergency Department.
Good evening. As Janet said, I'm Teresa Ellis. I began my career at Hutchinson Regional 21 years ago, and I spent the majority of that time in the intensive care unit as a staff nurse. Then I became a director there for 8 years. And then 2.5 years ago, with the opening of the new ER, I became the director of the emergency department. So, as all of you can imagine, in the ER, everybody's coming to receive a service in a quick manner, and they also want high quality care. And that's what we want for our patients. We identified that's been a long-term goal that we want to achieve more and more high quality but lower times. We want you to come in, be seen quickly, go home back to your life and your routine and not spend hours in the ER. So we chose this. We actually started 2.5 years ago, and the fiscal year 2015 and 16, we implemented several projects that did show improvement. But as you can imagine, this will be something we work on forever. We always want to be better. So this project will never stop. So at the beginning of the fiscal year for 2016, we decided that we needed to choose some more changes in our processes that could potentially get us to the next level. So we wanted to decrease the length of stay while maintaining our quality care. We never want to give up the quality for the length of stay. We wanted to anticipate any population growth we might have and be able to meet those challenges and still maintain a shorter length of stay. And I have up there improve employee satisfaction. You might want to know how that would improve employee satisfaction. If we have happy patients, we have happy employees. And we want you to come here for our services, and we want to do the best we can. And as always, we always wanted to keep our core values in place, which is our integrity, compassion, accountability, respect, and excellence, always in the forefront. So in October 2016, this was after a year of improvements. We thought, what next pieces of the elephant are we going to take bites off? And we added a throughput nurse position. We did some data research, and we know that our busiest times are from 11 a.m. to 11 p.m. So typically, when a patient would come into the ER, you would check in with the registration clerk and then go sit in the waiting area and wait to be brought back. We wanted to change that in the fact that if we have an empty room in the ER, we want a patient in it. We don't want anybody sitting in the waiting room if there's an empty room that's not expecting an ambulance patient, for instance. So the throughput nurse position enabled the patients that come in through the ER waiting area to be greeted by a nurse. So the first person you see in the ER is a nurse. A nurse by career and how we learn, we begin assessing patients from the moment you walk in. We are always assessing patients. So they get the first look and can say, you need this particular room, we need to get this patient back first. And so that starts from the moment you walk in. The other thing is, in the event that we do have all 18 rooms full, if you are seated in the waiting room, you have a nurse out there caring for you. That nurse will be checking on you, potentially checking vital signs, getting you comfort measures. Do you need a blanket? Are you running a fever? Can we start some Tylenol out there? They can, if you come in with foot pain, we know that the physician is going to probably want an x-ray. We can start that in the waiting room. So your care starts in the waiting room. And they're also really nice people. And we have a lot of compliments about just their overall personalities. And we chose those type of people for that reason. So in November of 2016, one thing we had already kind of identified was nurses spend a lot of time answering the phone or paperwork, things like that, and we had no clerical position in the ER. So we wanted to bring that position on board. That clerical person helps to field so many things that were taking our nurses away from the bedside. They were taking time away from you as a patient to do paperwork and things that someone else could pick up. So we did implement that, and they are very valuable because they also do a lot of audits on our charts to make sure our documentation is appropriate and complete, and that happens before you even leave our ER. So we know entrance is going to get the information they need. We have your record complete, so they're very valuable. In December of 2016, the way the process typically works in the ER is the physician will decide that you as a patient needs to be admitted to the hospital. And we make a call to the house supervisor, and then she calls up to the floor and gets a room. Well, we want to make sure as ER nurses that we give thorough report to the nurse that's going to have you as a patient, so they know, what have we done in the ER? What brought you in? What are we seeing? How can they continue your care upstairs the best? Sometimes those calls would take a little bit of time because a nurse upstairs may have 5 or 6 patients. They would be in another patient's room. They would be on the phone, have a call, be administering medication, maybe on a lunch break. And we would have to delay that patient going upstairs until we could give that verbal report to the nurse. So we implemented in December 2016 an actual form where our nurse, we had nurses from all the floors meet with us and say, what information is most important to you and what do you want to make sure we tell you? And we made a form out, and we actually handwrite that, and we fax it up to the floor where the patient is going to go. And upon receipt, then that nurse calls down and said, we have it and we can answer any questions. And that has expedited our ability to get the patient upstairs. It just took out several minutes. Sometimes it could be several phone calls back and forth, and we don't have that anymore. So that shaved off several minutes for the patients that are waiting. So with implementation of these, the average time from when the patient arrives to being placed in an ER bed now is at 16 minutes. Now that is on average. Most people, if we have a bed, like I said, you're directly taken to a bed. Of course, on a busy Saturday afternoon, evening, it's hard to avoid some waiting time, but the average time is at 16 minutes. The average time from when the physician gives the order to be admitted and when a patient leaves the ER is something else that we impacted. Our goal was 80 minutes, and we're at 57 minutes. So once that doctor writes the order that we want to keep you as a patient, then that's how long it takes to get you upstairs. And then the average overall time from the patient arriving to the actual hospital admission. And we start that from the moment you walk into the ER. Not when you get into a room. You're our patient from the moment you hit those doors. And we are down to 217 minutes. Now, I will say 2.5 years ago, we were closer to the 400 minutes. So these are the slides that show the first 6 months of July fiscal year, July, December of 2016, and now January to July of 2017. And our average door to bed time, like I said, from the moment you walk in till you get a bed in the ER, and you can see how drastically we've improved those. And then our average length of stay over a same 6-month, 2 periods. And you can see that on the right, we're down the average length of stay of 174 minutes. So we've made huge improvements. And like I said, it's something that will be ongoing. And we've asked ourselves, what will we do next? And so, of course, we want to maintain the current things that we found are working. And then we also have staff, which we've already implemented. We're doing some as-needed shifts on high census days. By looking at our data, we know what days we're the busiest. We know what hours we are the busiest. So we're just really flexing both our provider times and our nurses' times to meet that demand. And then we have also started following up 100% of our phone calls to patients. Everybody that's been to the ER gets a call within 48 hours. We want to know how your visit was. What can we do better? And we really enjoy reading those, and gives us ideas of what we can do next. We are going to start doing looking into point of care testing, and that means that instead of taking your blood sample and taking it to the lab and running it through machines, we will actually have machines within the ER that run those tests, so we'll expedite that whole process. We're training all of our nursing assistants to be phlebotomists, because sometimes they're spread a little thin. They have to draw blood on patients upstairs in the ER. If we have our own people located within the ER, we can make that process faster too. And then potentially a permanent roster position. We find on high census days, if we have that one nurse that isn't necessarily assigned to patients but can do a little bit of everything for everybody, it really helps the flow as well. So we're just very proud and very honored to have received this award this year, and we hope to be able to continue making the improvements over the next year. Thank you.
Thank you, Teresa. That's just a sampling of some of the kinds of projects that were submitted this year, and projects that go on all the time, whether or not they're even submitted for a contest like this. And I would encourage you tonight, after we're done, to look at the posters. Now, the first, second, third place posters are right over here on my right, and then around the room are the other posters that were submitted. And we do have some people here tonight to answer questions for each of those projects. It would be a little remiss of me if I did not thank the judges who gave of their time, and they're actually listed in your program. Laverna Shaw, Liz Pierce, Lois Schlickow, Lois Smith, Nick Baldetti, Phil Wood, and Travis Bowie were all our judges this year, and so we really appreciate them taking time to do that. Something else in your program that I failed to mention earlier, you'll notice Peggy Tuxhorn's name on there, and she sends her regrets for not being here. She had a death in the family and could not be here tonight, so that was why she's not here. I want to take just a couple of minutes, really quick, to share some recognitions and achievements with you, and you'll actually find most of these on our website. And we just wanted to take this opportunity to kind of reinforce some of those things. We are Joint Commission accredited. You know, colleges, schools, and different kinds of organizations can be accredited. Well, a hospital can be accredited too, and healthcare facilities can be accredited. And Joint Commission is not only a national accreditation, they're international, and they're a huge healthcare accrediting organization. So it's a big thing for us to be accredited by them. And not only the hospital, Hutchinson Regional Medical Center, but Hospice Home Care of Reno County and Health Equip, their home care services are accredited. And then within that, you have to be accredited to apply for special certifications. And last year, we did achieve a certification as a primary stroke center. And then with Jill's help, we're going to be applying for the certification for perinatal care this coming year. So we're excited about that. So those are some good things that are happening there. We have the Imaging Services Department. Staff must actually demonstrate competency and compliance with certain protocols in order for us to get this accreditation, and it's required for us to bill Medicare for services, so that's kind of a big thing. We got a Stroke Silver Award this year, and the American Heart, American Stroke Association recognized HRMC for its achievement with special improvement measures for 12 consecutive months. There again, you see that word improvement keep popping up. There's all kinds of improvement processes we have to comply with for that. And there you see Dr. Isaac with the Stroke Task Force with that plaque that we got for that. And then recently, the Reno County EMS, which is part of the Hutchinson Regional Healthcare System, shown here at the 2017 Kansas EMS Association's State Conference. They received the Kansas EMS Service of the Year Award, so we were very proud of them for that. And then you may have seen some information about the Consumer Reports Award that we got, or award, just the ranking. So we've been ranked by Consumer Reports as number 11 in patient safety out of 127 hospitals in Kansas. Some of the things they look at for this include infection rates, your readmissions, complications, adverse events. There's a lot of information that goes into that. So that's also a good thing to note. Hutchinson Regional Medical Center is also a level 3 trauma center, and we have received recognition as a verified trauma center by the American College of Surgeons. And this ties in with some of the services offered that Teresa is familiar with out of the emergency department, so that's another good thing. The CARF, C-A-R-F, this is the Commission on Accreditation of Rehabilitation Facilities. We're one of only 2 inpatient rehab facilities in Kansas that have this accreditation, so that's a big thing to us as well, and it took a lot of effort to achieve that. And then our laboratory is also accredited by the College of American Pathologists, and there's a very rigorous survey of laboratory services that you have to comply with to get that. So I just mentioned some of those to tell you that we pursue accreditations and certifications to raise the bar for our own selves so that we set the standard high to offer the best service we can. And you'll see on this slide the mission of the healthcare system, which is enhancing the quality of life through integrated healthcare. And so we believe that's by having these accreditations and certifications, it helps us accomplish that. So we hope you have found this interesting tonight. It's a little bit different kind of a first course presentation, but we would like to open it up now for questions. And I think Brant's got a roving microphone back there. Does anybody have any question for any of us tonight? We'd be more than happy to try to address that. No questions. We would please encourage you to, someone, do you see a hand? See a hand? Okay, here he comes with the microphone so we can hear you.
How long do mothers stay in the hospital after their baby is born?
Typically, our stay is anywhere from 24 to 48 hours. Now, if you have a C-section, sometimes we will keep moms up to that 3rd day, just kind of depending on how mom and baby are doing.
Times have changed, haven't they? We would encourage you to take a few minutes before you leave tonight and look at the posters. There's a lot of work that's gone into these, and we do have people here to talk with you about those. And is there anything else we need to address tonight? I'm looking at the back for head nods. Okay. Okay, thank you very much for coming. We appreciate you being here. Thank you.